Department of Radiology at Johns Hopkins. I have no financial disclosures. These are the objectives of my presentation today. I'm going to be talking about the nature of Black-white racial disparities in breast cancer mortality. I'll be talking about the causes and determinants of this racial disparities. I'll also be reviewing some of the evidence of racial disparities in access to breast imaging services. While I'm on that topic, I'll also be highlighting some of our newest advances in breast imaging technology. And finally, I'm going to discuss some of the impact of previous efforts that have been directed at reducing these disparities. So here's some background information. Compared to white women, the overall 5-year relative survival rate for breast cancer that was diagnosed from 2005 to 2011 was estimated to be 80% for Black women, compared to white women who had a 91% survival rate. The difference in survival is thought to be due to a combination of later stage at detection of the breast cancer cases and also poorer stage-specific survival amongst Black women. The later stage of diagnosis amongst Black women has been associated with multiple things, one of which is a lower frequency of screening mammography use. Another one is a longer interval between getting a mammogram. The third thing that has been associated with the later stage of diagnosis is a lack of timely follow-up when a patient does have abnormal mammogram results. So in looking at the trends in breast cancer incidence and mortality rates, historically, white women have had higher breast cancer incidence rates compared to Black women. However, in 2012, the incidence rates were noted to converge. And now the rates are estimated to be approximately the same for Black and white women, roughly the same. Now, despite the breast cancer incidence rates being roughly equal for Black and white women, Black women have an estimated 42% higher breast cancer mortality rate compared to white women. And this gap in mortality rate between Black and white women in the US has steadily widened since the early 1980s. So this is a figure here showing the trends in breast cancer incidence and mortality across races. So this first bar is non-Hispanic white women. The second bar is non-Hispanic Black women. The third bar represents Alaska Native and American Indian women. And then we have Hispanic women and finally Asian Pacific Islander. So when we look here at the first two bars, we can see that the incidence of breast cancer amongst non-Hispanic white women and non-Hispanic Black women is fairly similar. It's roughly equal, but the mortality rate is higher for non-Hispanic Black women compared to non-Hispanic white women. I do want to point out though that in this particular bar, it does look like it represents a slightly higher incidence of breast cancer for white women, which a lot of data does show that there is a slightly higher, although it's converging. So this is a bar here that it's a graph here that I got from Dr. Kanarak. I just want to show, it shows Maryland data. Okay, so here in the state of Maryland, we can see what the mortality rates look like amongst white and Black women. The first two lines represent white and Black women who are above the age of 50 and above. Now the bottom two lines represent white and Black women who are under the age of 50. And as we know, women who are older have a higher mortality, higher deaths from breast cancer, okay? And also are more likely to have breast cancer. So they have a higher number of deaths amongst women who are older. But when we look at the women who are older, we see that Black women have a higher rate of death from breast cancer compared to white women. And that, even though both groups of women have experienced decreased mortality over time, which is thought, a lot of it is thought to be due to better technology, better treatment. The better technology allows us to diagnose cancer earlier. So that's a good thing that the rates are dropping. However, this gap has remained, which is why this is a topic that's of importance. So this is another graph. So this one shows the cancer mortality differences in the US and in the state of Maryland. So in the state of Maryland, we can see here, the red dot represents white women in the state of Maryland. The blue dot represents, the blue line, sorry, represents white women in the US as a whole. And then the green line represents Black women in the state of Maryland, while the orange line represents Black women in the US as a whole. Okay, so we can see that in the US and in the state of Maryland, Black women have higher mortality rates compared to white women. Okay, and whether we're looking at this on the state level or on a national level, the trends remain. So the differences in stage at diagnosis is thought to be one of the major factors in the difference between racial mortality rates, the mortality rate differences amongst different races. And it's thought to be strongly associated with screening behaviors, the screening habits. Localized breast cancer is known to be more easily treatable and associated with a better prognostic outcome compared to being diagnosed with regional or distant stage disease. Of all the breast cancer stages, distant stage cancer has the worst prognosis. So the data has shown that white women and women of Asian Pacific Islander background have the highest percentages of localized breast cancer at diagnosis and the smallest percentages of regional and distant stage breast cancer. In comparison, though, Black women have the smallest percentage of localized breast cancer and the largest percentage of regional and distant stage breast cancer at the time of diagnosis. So this is a figure showing the distribution of breast cancer cases by the stage at the time of diagnosis. Now, the top section shows the distribution of stages, while the bottom section shows survival. Okay, so in looking at the different colors here, the green represents non-Hispanic white women, the blue is non-Hispanic Black women, teal is Hispanic women, the purple is Asian Pacific Islander, and orange represents the Alaskan Native and American Indian women. So I want to focus on white women and Black women in this, but just in keeping with the subject of this presentation. So we can see here that for looking at the different stages, okay, Black women have the lowest survival rates at each stage of diagnosis. So whether it be local stage disease or regional stage disease or distant stage disease, Black women had the lowest rate of survival from breast cancer. And then when we look up here at the different distributions, we can see that Black women are, of all the races, are the least likely to be diagnosed with local breast cancer and most likely to be diagnosed with either regional breast cancer or distant breast cancer. So I want to shift gears a little bit and talk about the causes and determinants of racial disparities in breast cancer mortality. So the causes and determinants are usually thought of in two levels. One is the patient, the factors that are related to patients themselves. And the second one is factors that are related to the community in which patients live in. So I'm going to start out by talking about patient level factors. Things like low family income level, limited level of education, whether or not somebody is employed, whether or not somebody has a usual source of healthcare, like a usual physician that they see, or whether or not they have continuous health insurance, as well as a lack of knowledge and the attitudes and behaviors that a patient has towards screening for breast cancer. All of these things play a role in whether or not a patient gets screened for breast cancer or even presents if they have a symptom related to breast cancer. Now, in discussing the community level factors, We look at things like whether or not the patient lives in a rural community or in an area where there's poverty or low per capita income. In areas where there's high rates of unemployment, or an area where there's limited healthcare resources, and areas where there's no proximity, there's a lack of proximity to medical services. All of those things can affect a woman's access to breast cancer screening and breast care. So this is a model depicting social determinants of health disparities, and it's this model was drawn up by Freeman and Chu. Now, this model is just showing the interplay of three major factors when looking at social determinants of health disparities. The three major factors are culture, poverty or low socioeconomic status, and social injustice. And it just is depicting the fact that the interplay of the interaction of these three major factors affects breast care of a patient along the spectrum from prevention, early detection, diagnosis, treatment, quality of life after treatment, and whether or not a woman survives or dies from breast cancer. Now, in looking specifically at these three categories, the first one is poverty and low socioeconomic status. Again, lack of primary care physician, whether or not a woman has access to medical care. The idea of competing survival priorities is just addressing the fact that for some women, they may choose to forgo breast cancer screening or even drawing attention to the fact that they have a lump because they're pressed with other concerns like food, getting food on the table for their families, or finding shelter. So if a woman is faced with those situations, they have competing survival priorities, and they may choose to seek shelter and food over drawing attention to a breast symptom or choosing breast cancer screening, for example. Lack of information about the importance of early breast cancer detection also plays a role, and lack of physical activity or having poor nutrition or being obese, all of those things play a role. Now, culture also has been shown to play a huge role in health disparities. Spirituality, which can actually, research has shown spirituality can be pro or against breast cancer screening behavior. And by that, some studies have shown that women who are more involved in their spirituality sometimes are more likely to pursue breast cancer screening as a result of the support of maybe their church group or whatever religious organization they're a part of. On the contrary, for some women, spirituality actually deters them from seeking medical attention because they're trusting everything to a higher power. And so as a result of that trust in a higher power, some women may choose to forgo medical care entirely. And so spirituality, plays a role both ways in different women. And also, there's the perceived susceptibility to breast cancer. Studies have shown that some American women, some Black women, are less likely to believe that they are susceptible to developing breast cancer. And even in women who have a family history of breast cancer, sometimes they don't accept or don't realize that they are susceptible to this. Cultural beliefs and attitudes about breast cancer play a role, as well as a general mistrust of the healthcare system, which has historical basis in the United States. Now, the next category is the social injustice. There is there's a lack of research in this area, but it is believed that racial prejudice and also whether or not a person feels that they have been discriminated against plays a role in their breast cancer screening behaviors. So I want to talk about evidence for racial disparities in access to breast imaging services. Okay, so I'm going to highlight a few studies that talk about racial disparities in access to breast imaging studies. And the first one I want to talk about is this racial disparities in screening mammography in the United States. It's a systematic review and meta-analysis that was performed. It was performed recently and published in February 2017 in the Journal of American College of Radiology by a group at Mayo Clinic. And this study looked at, this meta-analysis looked at studies that were published between 1946 and 2015 and compared utilization of, it looked at studies that compared the utilization of mammography amongst different racial groups. There were a total of almost 6 million patients included across 39 relevant studies. In this patient population, about a third of them were Black, 43% white, 17% Hispanic, and about 6% Asian or Pacific Islander. They found, and in this meta-analysis, they found that Black and Hispanic populations had lower odds of using screening mammography compared with the white population. They also found that in African Americans, the disparities were present not only in the age 40 to 65 age group, but also above 65. And for Hispanics, they only found the racial disparities to be present in the 40 to 65 age group. And there was no difference in utilization of mammography between Asian Pacific Islanders and white women. So next study I want to look at is a study that evaluated what happens when a woman has an abnormal screening mammogram. Are there racial disparities in the follow-up rates? So this study was titled "Inadequate Follow-up of Abnormal Screening Mammograms: Findings from the Race Differences in Screening Mammography Process Study." So this was a study published in 2005 by a group at Yale. And they set out to identify factors that were associated with inadequate follow-up and to determine if that differed by race or ethnicity. They looked at 176 women who had an abnormal or inconclusive mammogram. And this women, so of this women, they had 635 African-American and 816 white women. These were women who underwent screening at 5 hospitals in Connecticut between 1996 and 1998. And they found that over 28% of the women that required immediate or short-term follow-up did not receive that care within 3 months of the recommended date. The factors that were associated with a lack of adequate follow-up was being African-American, having pain during the mammogram, or not having a usual care provider. So this is a figure here where just showing the characteristics that were associated with inadequate follow-up after an abnormal screening mammogram. So they found that African-American women were 3.5 times as likely to have, 3.5 times more likely to have inadequate follow-up after an abnormal screening mammogram compared to white women. Right? And this was statistically significant. The only other factors that were statistically significant in this study were not having a usual care provider and having a lot of pain during the mammogram. So for women who do present for their follow-up after an abnormal mammogram, is there a difference in the amount of time it takes them to present for that follow-up? So this is a study here that was published in 2008 that was focused on answering that question. So they looked at racial ethnic disparities in the time to follow up after an abnormal mammogram. This was a retrospective cohort study that included almost 7,000 women that had an abnormal mammogram and had a documented follow-up from January 2000 to December 2002. Now they looked specifically at the number of days between when the abnormal mammogram happened and when the follow-up imaging happened, or biopsy for women who went on to have a biopsy. So they found that the median number of days from to the time of diagnostic follow-up after an abnormal mammogram was greater for African-American women, it was 20 days, and Hispanic women was 21 days, compared to non-Hispanic white women who had a median number of days of 14. They also, after controlling for age, the BI-RADS assessment category of the report, the insurance status, location of the provider practice, and the median household income, they found that racial and ethnic disparities remain significant. So this is a table from that study, just showing that African-American and Hispanic women were about roughly 20 to 23% more likely to have a delay in follow-up after an abnormal mammogram. And so finally, the last article I want to talk about here is in this section of the talk is this one that looked at the time from screening mammogram to biopsy and from the time of biopsy to breast cancer treatment amongst Black and white women. This study focused on women Medicare beneficiaries that were not participating in a health maintenance organization. This was a study out of Tennessee, and it was published in 2016. So the study looked at the relationship between a number of days between an abnormal mammogram biopsy and treatment amongst Medicare Part B beneficiaries, ages 65 and older. And they had so they looked specifically at a cohort of non-Hispanic Black women and non-Hispanic white women that are in the United States and didn't receive any services from an HMO organization. These women were randomly selected from the Center for Medicare and Medicaid Services file. They followed the cohort from 2005 to 2008 using claims data from Medicare and Medicaid services. And in their sample, they had almost 4,500 women who had a diagnosis of breast cancer. And so they found that Black women had an average of almost 17 more days between biopsy and treatment, and almost 16 more days between having a mammogram and treatment compared to white women. So this is a table from that study, just showing the times from mammogram to biopsy, biopsy to treatment, and then overall from mammogram to time of treatment. So looking here in the section on race, there's a row here for Black women and a row here for white women, showing that while the time from mammogram to biopsy is slightly lower for Black women, the time from biopsy to treatment is a lot higher for Black women, and the time from mammogram to treatment is a lot higher for Black women compared to white women. And so I want to move on and talk about racial disparities in the access to advanced imaging technologies. You know, in breast imaging, we've had an exciting time over the last few decades in that we've had improvement in technology that's allowing us to catch cancer at an earlier stage and allowing us to reduce our false positives. And so I'm going to talk about some of this advancement in technology that we've experienced in breast imaging. I'm going to start off by talking about digital breast tomosynthesis. So I want to talk about the impact of tomosynthesis. Three of the main things that tomosynthesis has done for breast imaging and for patients is that it's increased our cancer detection rates. Secondly, it's reduced our recall rate from screening mammography. So what does that mean? That means that when women present for a screening mammogram, fewer of them are told that they have an abnormal mammogram and have to come back for additional workup to see if this finding persists or not. Okay. And then the third thing that it's done is that it's improved our diagnostic workflow such that when a patient comes in for diagnostic evaluation, we end up requiring fewer mammographic views because we're able to characterize and localize findings better, which then also results in lower radiation for patients if they're getting fewer views. So I want to start off by I'm going to use some cases here to demonstrate these points. So for the first point, this was a 65-year-old woman who presented with a palpable lump in the left breast that was detected by her physician. So this patient actually saw her physician. I believe it was she saw an OB/GYN doctor 9 months before this mammographic images were taken. At that time, we were just about to acquire tomosynthesis. So we were doing full field digital mammography, also known as 2D mammography. We didn't have 3D tomosynthesis yet. So a 2D mammogram was done, which was normal. Ultrasound was also done at the area where the patient's doctor was feeling a lump, and it was normal. So the patient was told to follow up with her doctor, as we do for patients who have a palpable lump. So patients followed up with her doctor, who kept an eye on her. And 9 months later, the lump was persistent and the doctor remained concerned. So the doctor sent her back to the clinic, the breast imaging clinic, with the specific instruction that she wanted the patient to get 3D tomosynthesis. So the patient came to us and got the 3D tomosynthesis. These are 2 images of the left breast that were obtained during this visit. There is a finding, it's a very subtle finding. It's in the lateral aspect of the left breast. And when we did the tomosynthesis spot compression images, we could see that this finding persisted. There is a very subtle area of architectural distortion where you can see the lines radiating from a point here, right here. This finding was biopsied using stereotactic guidance because the finding was not visible in ultrasound at all, and this ended up being an invasive ductal carcinoma. Only visible in tomosynthesis, not seen on ultrasound, and not seen on the 2D mammogram. So next, tomosynthesis helps to reduce our mammography callback rate. It does this in a couple of ways. It does this by demonstrating that asymmetries, that in cases of asymmetries that are due to superimposition of the fibroglandular tissue, the tomosynthesis helps us to see that more clearly, thereby helping us to avoid recalling the patient from screening mammography. It also helps to reduce recall rate by localizing skin findings. So in the past, before we had tomosynthesis, if we saw an area of calcifications that we were not sure were in the skin, we would have to have the patient come back. So we'd recall the patient from screening mammogram so that we could do additional views to prove that there were benign skin calcifications. Now, with tomosynthesis, we often don't need to do that because we can actually just scroll through and see that these findings are on the skin slice, and therefore they are skin findings. So this is a case of a 61-year-old woman who presented for a screening mammogram. So these are 2D full field digital mammography images. This image here is the left craniocaudal view. And on the right here, what I have here is the view from 6 years prior. So this patient was recalled from screening because there was a finding seen that was thought to be new from her mammogram 6 years ago. When she came back, we did the tomosynthesis images, and unfortunately, so these are the tomosynthesis slices, but unfortunately, I can't get it to play. But what it showed us was that that area was completely normal, and it was just normal tissue. And so this is a case where if this patient had the 3D tomosynthesis up front, then they probably wouldn't have needed to come back for additional evaluation. And that's just an example of how tomosynthesis reduces our recall rate. Finally, tomosynthesis helps to improve our diagnostic workflow. And I'm going to show a case here of that. This is a 65-year-old woman who presented for screening mammography. On the mammogram, there was a finding seen as a subtle finding seen in the left breast here on one of the views only, just one of the views. It was not seen on the other view. So when she came, we did 3D spot compression views. So tomosynthesis spot compression views of that finding. And you can see this beautifully demonstrated irregular mass with speculated margins. You can see the lines radiating out of this mass. So this mass was so well depicted on the tomosynthesis images that we went straight to ultrasound. We were able to find a correlating mass on ultrasound. So this is the mass seen on the mammogram. And this was biopsied and shown to be invasive ductal carcinoma. I want to switch gears and talk about breast MRI, which is the other technological advancement that we've had in breast imaging within the last couple of decades. So it's been pretty exciting. We use breast MRI for multiple reasons. And this is a list of the accepted indications for breast MRI. We use breast MRI to screen patients who are known to be at high risk for breast cancer. We use breast MRI to evaluate patients who have been newly diagnosed with breast cancer because we want to evaluate the extent of disease in the ipsilateral breast. That's the side of the breast that has cancer. And it's also helpful for screening the contralateral breast, the other breast, to see if there's an incidental cancer in the other breast. We also use breast MRI to evaluate patients who are being treated, breast cancer patients who are being treated with neoadjuvant chemotherapy, to see how the cancer is responding to chemotherapy. Breast MRI is also helpful for evaluating patients that have metastatic axillary carcinoma of unknown primary. It helps us to assess the breast tissue and see if there is a breast primary that was not visible in the mammogram. Breast MRI is also helpful for evaluating implants, silicone implants, to see if they're ruptured. And finally, we use breast MRI in some cases. If a patient has had a benign MRI guided biopsy, we use it to follow, to keep an eye on them and just make sure that that area remains okay. We usually just do one follow-up after the benign biopsy. So this is an example here. This is a 66-year-old woman with history of treated right breast invasive ductal carcinoma who had right lumpectomy 6 years ago. She presented for high-risk screening breast MRI. So, and her mammogram was negative. On the MRI, there was an irregular enhancing mass seen, denoted by the pink arrow here. And this mass was only seen on MRI, was not visible on ultrasound. Ultrasound was done to try to find it, and it wasn't visible on ultrasound. So we did an MRI guided biopsy, and this mass was shown to represent an invasive lobular carcinoma. So this was a finding that was picked up on the screening MRI examination. So with all this advances that we've experienced in our imaging, breast imaging technology, the question remains, how does this impact access to breast imaging? There's actually concern that with advances in imaging technology, it represents opportunity for unequal distribution and unequal adoption of newer, more advanced imaging technologies, which can then worsen health disparities. And the reason is that a lot of these advanced imaging technologies tend to be less readily available and accessible geographically to patients. Oftentimes, whether or not a woman is in an urban versus rural setting, or whether or not they're at an academic center versus a smaller facility out in the community, might affect whether or not the woman has access to this advanced imaging technologies. Another thing to keep in mind is advanced imaging technologies are often associated with higher out-of-pocket expenses for patients, and for example, higher copays for patients. So I want to just talk next about the impact of prior interventions on racial disparities. So there have been a lot of interventions that have been evaluated for reducing breast care disparities. And these include reminder-based interventions directed at patients, like letters to patients telling them, oh, you're due for your exam, phone calls to patients, using patient navigators, using more multifaceted patient-directed interventions, like interventions that target both financial and logistical barriers that women may be experiencing, such as giving free mammography vouchers, providing transportations to patients to and from their appointments, providing dependent care so women can go in for those appointments, or even assistance with scheduling the appointments. There have also been interventions directed at breast cancer treatments, such as expediting the initiation of treatment by using case management-based interventions. All of these things have been shown to be helpful for reducing disparities. Another thing that has been proven to help reduce racial disparities is the Patient Protection and Affordable Care Act. The national health reform that was signed into law in 2010, that was aimed at increasing accessibility for millions of Americans. It has helped to improve access to breast care in many ways. One, it's mandated coverage of screening mammograms by insurance plans. Two, it's ensured that health insurance companies will no longer be able to deny an individual health coverage because of prior diagnosis of breast cancer, for example. Thirdly, it's prevented health insurance companies from placing an annual or lifetime limit on the amount of coverage that a breast cancer patient can receive, which has been of benefit to our patients. So there have been a few studies so far evaluating the impact of the Affordable Care Act on disparities related to breast care. There was a recent study that reviewed medical expenditure panel surveys from 2008 to 2015 and found that the Affordable Care Act helped to narrow racial ethnicity disparities gap in health insurance coverage. And amongst breast cancer survivors. It also helped to narrow the gap in healthcare utilization and out-of-pocket prescription drug expenses for patients. They also found that because of the Affordable Care Act, Black breast cancer survivors had an increased use of mammography services. So the ACA has been shown to reduce disparities gap in access to healthcare, particularly breast imaging services. It's important to note that there is need for more research in effectiveness of all of these interventions in reducing disparities across the whole spectrum of breast care. Additionally, we need to evaluate culturally sensitive ways of bridging the gap and developing trust in the patient-provider relationship to mitigate effects of historical distrust related to past instances of racial discrimination in institutions by healthcare organizations. So that is an issue when you look at racial disparities in the US. You have to definitely look at it from the context of history. And I think any intervention that's going to be successful has to keep in mind the historical context of racial disparities. So I want to just finish up by talking about some other recent interventions that have been directed at reducing disparities. And so one of them is the improved availability of same-day imaging appointments. So there was a study that was published less than a year ago. It was published in a journal of the American College of Radiology by a group at Massachusetts General Hospital. And what they did was they created a same-day breast biopsy program and evaluated its impact on disparities in time to biopsy. So what they did was they identified patients that had diagnostic mammograms that resulted in a biopsy before and after implementation of the same-day biopsy program. And they found that for all patients, the same-day biopsy program decreased the median time from the time of diagnostic exam to biopsy from 8 to 0. They also found that during the implementation period, non-white women and having Medicare insurance were factors that were associated with longer delays to biopsy. And during the post-implementation period, there were no disparities that persisted. So basically, just by offering the same-day biopsy program, they were able to eliminate disparities in the time from biopsy recommendation to performance. So the second thing I want to talk about is the improved risk prediction algorithms and also telephone communication of abnormal screening mammography results. So again, a group out of MGH in association with a group out of MIT. So they worked together to create a deep learning mammography based model that was aimed at improving breast cancer risk prediction for patients. So this was also published last year in the Radiology journal. So the study was done by a group of breast imagers and computer scientists in Boston who developed this artificial intelligence risk prediction models. And their goal was to integrate standard breast cancer risk factors with information that's embedded in digital mammograms. And they created this hybrid deep learning model that identified women who are at high risk for breast cancer and placed 31% of all patients with future breast cancer in the top risk category, compared to only 18% placed by the Tyler-Cuzick model, which is the model that's most often used clinically. Now, the hybrid model was equally accurate for both white and Black women, whereas the Tyler-Cuzick model was less accurate for Black women compared to white women. And so they found that this artificial intelligence models demonstrated statistically significant performance improvements for Black women and this is a group of women where there is belief that existing risk prediction models perform poorly. So finally, I want to talk about a study that was published very, very recently, just last month, by our group here at Johns Hopkins. So this study was looking at the impact of telephone communication on patient adherence with follow-up recommendations after an abnormal screening mammogram. So the MQSA, which is the Mammography Quality Standard Act, requires that women who get a screening mammogram be sent a letter with their results. Okay, so what our group here did was, in addition to the letter, we started having patients receive phone calls if they have an abnormal screening mammogram. And so, and now the study here was aimed at looking at changes, the impact of this new workflow. Okay, so this was a retrospective study that reviewed data from screening mammograms at our institutions. In 2011, that was our pre-intervention group. 2014 was the early post-intervention group, and 2018 was the later post-intervention group. And we compared patient adherence with timely follow-up diagnostic mammography, defined as patients returning for the follow-up diagnostic mammography within 60 days. So what we found was that in 2011, 73% of patients returned for their diagnostic follow-up within 60 days, compared to 87.6% in 2014 and 90% in 2018. And the difference was statistically significant. The median time to follow up for those patients that did return was 28 days in 2011, 15 days in 2014, and 9 days in 2018. So the time progressively got less, the median time that it took for patients to follow up. Okay. So we did find out that the effect of this implementation of this telephone protocol depended on race. And specifically, the follow-up rates increased more for non-Hispanic white women than it did for non-Hispanic Black women. Okay, after stratifying by race, we found that non-Hispanic white women were 4.6 times more likely to follow up in the later post-intervention group than the pre-intervention group. And in comparison, the non-Hispanic white women were only 2.7 times more likely to follow up. So this intervention benefited all women, but the benefit was seen more in non-Hispanic white women. So this is a figure from that paper showing, so this purple bar represents pre-intervention group, the blue is early post-intervention, and the green is later post-intervention. This represents white women, Black women, and Asian women. So we can see that Black women have the lowest rate of diagnostic follow-up of all the three groups. And we can also see that for all the groups, there's an increase. Except for the Asian group, there was an increase from pre to early intervention, but that increase did not persist. The main thing I want to point out just is that the Black-white disparity persisted even after implementing this new protocol. Okay, so in conclusion, over the past several decades, the Black-white racial disparity gap in breast cancer mortality has persistently widened. There is a number of causes and determinants at play, and these causes and determinants are both complex and multifaceted. There are some promising interventions that have been studied for reducing these disparities, including using patient navigators and interventions and telephone calls, same-day appointments, and they are all very promising. There's definitely more research needed in elucidating the causes for racial disparities and how best to tackle them in light of the historical context of the United States. So I want to just acknowledge, Dr. Noma Kanarek for providing data on the state level breast cancer statistics in Maryland. I also want to acknowledge Dr. Avon Connor, who served as the advisor for my MPH capstone, which was the basis for this presentation. Thank you for your time. These are my references. Thank you for your attention, and I'll be happy to take any questions.
Well, thank you so much, Dr. Oluyemi. We have some time for questions. I'm not sure how you would like to do it, but there is a question here in the chat. So if any of you have a question, feel free to put it in the chat, and I'll scroll down to it. So one question here is, have you accessed the social disparities of health in EPIC, and wondering how you think of that, what you think of that.
Okay, so one moment.
So information about social disparities in EPIC.
Okay, so when we look at information on social disparities in EPIC, there's definitely a paucity of data available in EPIC. I would say, even when we've done studies looking at where we want to look at social factors like race, we often have race data, but our race data is left to what is provided within Epic. So all we have for race data is just what's provided within Epic. So, and in terms of other social data, like if a patient lives alone, what their income level is, what their level of education is, annual family income, those are things that we have very limited access to in Epic. That, as I will acknowledge, that has been a challenge when we've tried to do some of the research work that we've done in our group.
So just a quick question about that.
Is there a recommendation for additional variables that might be feasible to add to Epic?
Sorry.
I was just going to say they have a whole sort of dashboard on social determinants of health in Epic with where entered data from other participants like social work, nurse, puts in together a like a wheel that they have that is the social determinants of health wheel that has a good indicator of what their level of social determinants of health is. And I don't know if you had seen that, or because it includes things like, you know, is the patient live in a food desert? Do they have access to a primary care physician, insurance, those kinds of things. So it's a social determinants of health indicator wheel is the best thing I can use to describe it. And I have looked at it, and I haven't seen a lot of providers using that. I've seen some data because it collects data from many people who enter data into Epic. It just pulls it together for that. So that is one of the things that they instituted in Epic. I think it was an upgrade last year. So I just had wondered if you'd used that and what you'd thought of it. So
I never used it. It sounds great.
Yeah, so look for it. Yeah, you can just do the search within Epic on social determinants of health, and it will bring up the wheel, and it has all the components of all of the pieces of data that make the wheel. So take a look.
Thank you. That's good to know. Thank you.
Thank you. Nice presentation. Thank you.
Thank you.
So we had another question about available data, like the graph that I supplied you, but having to do with histology of the breast cancer, and can we look at triple negative breast cancers, you know, for the state and for the country. Have you tried anything like that?
No, I haven't. It sounds interesting, but I haven't.
Yeah, I think the data are hard to come by, but there, you might try the SEER database, and of course that's not the whole country. And Avon Connor and one of her students actually requested data from the state of Maryland, so we could potentially get that. The information about histology has only recently been required to be reported to the registries. And there were a good number of cases where it wasn't reported. So it was still gathering some, you know, quality, if you will. So I have a question though about one of your early studies that you showed that pain predicted whether women would complete the recommendation for biopsy after that screening mammogram. So do any of your technologies have a better pain profile, if you will, that might encourage patients to come back?
I mean, so we do try in our clinic to honor patients' requests. We have, you know, some patients that know when they come for their mammogram that that's the technologies that they've had the best experience with, and sometimes they'll request that technologist, and we try to honor that. If the technologist is there, she will see the, you know, she'll see the patient. We also try to respect a woman's pain tolerance. So if a woman says that's the most pain that she can tolerate and she doesn't want any more compression, then our technologists will usually try to honor that as well. Okay.
So there's an additional question here from Lisa Mullen. My research focuses on characterizing environmental exposures to endocrine disrupting agents and examining their potential health effects on highly vulnerable, low-income, and minority populations underrepresented and understudied in public health research, including occupational populations, pregnant women and women of reproductive age, and children. I, I guess that's not really a question, but it's
I think she said disregard and she's going to repost it. That was Nicole Hughes, yeah.
okay. All righty. Other questions? I see Naji Corey, unmute yourself, sir.
That was a great talk, wonderful, excellent. I'm distinguishing not the discrepancy, but the two parts in looking at those, the underserved patients. One that really are under your management, that is from the time they have made an entry for their screening till the treatment, you're able to affect that with your team and so on. My question addresses the pre-mammogram, where you said there were delays, non-compliance, and I wonder first whether these are in parallel with how the African American deal with other diseases, their cardiovascular disease with diabetes, affected by the social issue, and whether that the approach towards them is much more global than just breast. And I want to get your comments about that.
That is a really great question. That's a very great question. And in fact, when I was doing the literature review for this presentation, there were several papers that I found where they were not just focusing on breast cancer screening behaviors, but they were focusing on screening behaviors for other cancers or screening behaviors for cardiovascular issues. And so I think there's definitely a recognition that a lot of this, the social determinants and, you know, the causes and determinants of breast cancer disparities affects other healthcare conditions as well, like you rightfully pointed out. And it is a really good point that you bring up, that perhaps the research that we're doing in addressing breast cancer disparities might be served by collaborating with people who are addressing disparities affecting other healthcare conditions as well. And perhaps there's room to work together on that.
Terrific idea. Thank you so much, Eniola, for presenting today and bringing this topic to us. You know, we've been wed to mammogram for a long time, and I can see that things are changing out there, and hopefully that and other factors will work to eliminate the disparities. It's certainly necessary here in Maryland. So thank you all for coming to another talk in a couple weeks. Bye-bye now.
Thank you.